Hello everyone and welcome to another SDF COVID-19 webinar. I'm Dave Little, CEO of SDF, and today's webinar will be discussing medically assisted treatment during COVID-19 and beyond. This webinar will explore the changes that have occurred with the delivery of medically assisted treatment during lockdown on after lockdown on the 23rd of March, and what lessons can be learnt moving forward beyond COVID-19. In particular, we've seen a significant shift away from daily supervised dispensing of methadone and buprenorphine during the lockdown. From our own survey with those on MAT, admittedly a small sample so far, there's been significant positive feedback on this change. It's important that all this learning feeds into a reassessment of current practice and approaches moving forward. This learning will also feed into the development and implementation of the medically assisted treatment standards, which are being driven forward by the Drug Death Task Force. To discuss these issues, we are joined by three speakers: Danny Mogford, NHS Lothian, Jamie Tidder, NHS Borders, and Saket Priyadarshi, NHS Greater Glasgow and Clyde. We'll hear from each speaker in turn, and then we'll have a question and answer session at the end. Attendees can submit questions throughout the webinar. The questions tab appears on the control panel, which should be on the right side of your screen. Austin Smith, my colleague, will join us for the discussion at the end of the presentations, where he will summarize the questions being asked by the webinar attendees. So first, I'd like to hand over to our first speaker today, Danny Mogford. Over to you, Danny. Thanks.
Hi, thanks, Dave, and thanks for asking me to talk today. It's a real pleasure. So what I was going to propose to do was talk specifically about my own service, which is the West Lothian Community Addiction Service. We're part of NHS Lothian, so I think probably some of the issues that we've had are health board wide, but I guess I'm speaking for myself. And what I propose to do is talk a little bit about what we did in response very quickly at the end of March when the lockdown happened, and how we've managed that during this period. But then I guess what we're doing now to try and make a plan going forward, and how that might change some of the ways that we do things. So, you know, like all services, we had a very rapid relaxation of supervision and dispensing requirements at the end of March. This was driven by a very rapid and somewhat lacking in notice withdrawal of usual services from the community pharmacies. And so we, from our entire caseload of prescribing, which is more than 400, we basically went to no supervision and very relaxed dispensing. On a very small case-by-case basis, we were able to negotiate a little bit of supervision for very high-risk situations, particularly people who maybe had recent non-fatal overdoses or just been released from hospital. But the vast majority of our caseload had a very significant change in how we were delivering their treatment. I think the other thing to say is that where patients have been asked to self-isolate or to shield, we've been using our nursing teams to home deliver methadone, which I think is something else that's a bit unprecedented for us. This has been largely successful, and there's been a big resource implication for our nurses and our service, and part of that has been that our usual reliance on third sector partners to help out with some of our work, so particularly our assertive outreach work in trying to get people to appointments or doing some of the psychological work has not been able to go on. So we've been doing a lot anyway, and the additional burden of having to deliver has been hard, but we've done it. And you know, I'll talk a little bit about how our nursing staff have managed, but I'm enormously grateful for the hard work that they've done. I think it's been a very rapidly changing situation. So there were some initial offers of help from the local authority, but unfortunately they never really eventuated. So I guess we, as the NHS service, were keeping on going. So we just continued. I guess the other big challenge we've had is we rely on local laboratory oral toxicology for monitoring treatment, and that has been withdrawn on infection control grounds. So we're not, you know, in addition to quite relaxed dispensing, we're also not monitoring the treatment how we would normally do. So I think that's kind of the quick overview. I don't think that would be a surprise to anyone. I think that probably describes most of the services in Scotland. I don't have firm figures, but my general sense is that we haven't seen an obvious spike in adverse events in our caseload, and I am surprised by that, but also delighted. I think, like lots of people in my position, I spent the first, or maybe the last week of March and the first couple of weeks of April having a few sleepless nights, aware that there were prescriptions floating around with my signature on them for treatments that in other circumstances I would have felt very uncomfortable with, and I was genuinely quite fearful that we were going to have a spike in overdose deaths on our caseload from prescribed medication, and I'm really delighted to say that doesn't seem to have been the case. I am sort of the corollary to that is I am aware, although again it's not official, and I think these things will get worked out as time goes on. But I am aware of some deaths in the area where there is at least a suggestion that prescribed methadone has been implicated, but that's been for people who haven't been in treatment with us. So I think, you know, although a lot of this has gone well, I'm mindful that there probably has been a slight shift in what's happening more widely in the community, and certainly anecdotally, patients tell me that that street methadone and buprenorphine is much more available than it has been in the past. I guess what is important for me is that despite all these challenges, we have continued to offer a treatment, not only to patients who are already on our caseload, but we've continued to take new patients. We've continued to initiate treatment. We are still, I think, meeting our waiting time targets. You know, for all of that, I'm incredibly proud of our nursing team. They're all running really big caseloads. They're picking up a lot of extra work, and to be able to support us in that has been an enormous achievement. The other thing that we have, it sort of, I guess, coincided nicely in terms of timing, our health board added a prolonged release injectable buprenorphine to our formulary some months ago, and so we've initiated quite a number of patients on that. We think have somewhere in the order of not quite, but approaching 10% of our medically assisted treatment caseload on injectable long-acting buprenorphine, and that has been a real success, and it has meant that a growing portion of patients are no longer having to attend pharmacy and actually getting a lot of other benefits from that as well. Again, that has stretched us. We're having to run depot clinics, which as an addiction psychiatrist, I didn't necessarily think that I would ever be doing, and that has had resource implications, but I guess, as I say, I think the outcomes have been worth it. So, and I guess going forward, we hope to expand that and continue it. We are not proposing doing a wholesale return to supervised methadone or buprenorphine as capacity starts to return in the community pharmacies. I'm hoping that as a clinical team, we'll capitalise on the progress that a portion of our patients have made, and we will approach changes to treatment from here on a case-by-case basis. So as toxicology becomes more available, that will be one of the tools that we have in our toolbox for assessing that, but we'll be keen to continue to see our patients. If people are telling us that they've done better with a more relaxed approach to their treatment, we are certainly up for negotiation around that. I don't want to disregard what people have managed to achieve despite all this. So I don't know, I hope that Dave is happy that that was sort of roughly what I agreed I would say. I'm happy to answer questions later, but I think that's probably a reasonable overview of how we've managed and where we're going from here.
That's great. Thanks very much, Danny. That was a really interesting overview of what's happened so far. Yeah, we'll come back to questions from the audience at the end, but thanks for just now. Can I go on to our second speaker, which is Jamie Tidder from NHS Borders?
Yeah, thanks very much, Dave, and thank you for inviting me to speak today. I do have a few slides. You're pleased to know that there's not tons of stuff on the slides, but mainly just that I'll never remember any of the numbers without them. So I'm Jamie Tidder. I'm the consultant for NHS Borders. So we obviously are probably the smallest health board in Scotland, and we have a single addiction team that covers really quite a large geographical area, you know, right from sort of Eyemouth across to Galashiels and then down, you know, through to sort of, you know, Jedburgh. So certainly we've faced challenges here with the geography, but a lot of the challenges we've faced really have been very similar to Danny. So I'm going to try and avoid just repeating everything that he said. Can we go to the next slide? So just to put in context, these figures won't be completely accurate. We won't capture everyone. So before COVID, our sort of culture in the service has been very conservative around supervision. Certainly when it says that 95% of people who we were prescribing methadone for were supervised, that doesn't mean daily supervised. So, you know, there'll have been people who are maybe picking up weekly or twice a week, but it would be that the supervision would still be there on the collection day, and that would be included in those figures. But very much in keeping with Danny, obviously a massive shift in our service when essentially overnight we've moved from having complete access to supervision to community pharmacies simply saying that they can't do it. And certainly we had an initial couple of week period where I genuinely don't know who was being supervised, but I would imagine it would be sort of nearly no one in the borders. So very much in keeping with colleagues in other areas, we conducted a review of our entire caseload and we negotiated with community pharmacies to try and keep the people that we felt there was the highest level of risk in supervision. But as you can see from the numbers on the slide, in essentially a massive change in prescribing. And alongside that, we also reduced the frequency of pickups. So a lot of people who were on, you know, daily pickups prior to COVID have had that frequency reduced. Again, very much in keeping with Danny, one of the real challenges we've had has been people who obviously have either been symptomatic potentially with COVID or particularly people who've been on the shielding list. We're very lucky we were given the shielding list from the health board matched to our patients. So we were able to get in touch and to try and organise that with them. And again, I don't want to repeat everything as Danny said, but we've had similar issues with a lot of staff time taken dropping off methadone to people. And again, I'm very grateful to the team who've worked really hard to do that safely and where it's been needed. Yeah, so I've not put everything on this slide. I'll talk about a couple of other bits that we found challenging, but I suppose just overall our experience of reduced supervision. So I suppose the first thing to say is that we have had very clear reports in this area, both from colleagues in the police, colleagues in community pharmacy, and a lot of both anecdotal reports from patients generally, but also patients talking about very specific cases of diverted methadone. And I have been really quite concerned about the amount of methadone that probably is being diverted. In terms of overall drug deaths, we've continued to have drug deaths, probably at around the same frustratingly high level that it's been in the last couple of years. We've not had an obvious spike, although obviously statistics over time will need to be looked at. What we have had is 2 drug deaths where we were contacted by the police to say that large amounts of diverted methadone were found at the scenes of those deaths. And I certainly found that actually very difficult emotionally because the diverted methadone was still in named bottles and the patients that it had come from, of course, were all people that I had agreed to relax their supervision. And I suppose what I really wanted just to reflect on is that it was quite hard at that point not to go with a knee-jerk response of just saying, right, everything kind of back to how it was before. And we've really tried very hard not to do that. But at the same time, we have recognised that certainly in our service, we feel that we have needed to try and reintroduce supervision where we've identified risk as quickly as possible. To counterbalance that, just very much in keeping with Danny, it's been very obvious that there have been patients where perhaps actually our sort of historical practice has maybe been overly conservative, and it's been really great to see people doing fantastically well with reduced supervision and pickups, and patients reporting positive benefits from not having to attend daily at pharmacy. And very much in keeping with Danny, I am very, very keen to try and see if we can maintain that for people where there is evidence both in presentation and engagement and toxicology that they're doing well. Can we move on to the last slide? So this is the last slide, and then I'll just talk about a few broader points. So I can't give you the figures, and unfortunately there is a bit of a lag in our prescribing data, but as of towards the end of last month, you can see that obviously we have started moving people back into supervision. Those numbers almost certainly will have gone up again over the last few weeks. This has been done very much on the basis of individual assessments. As I said before, it's not our aim to go for a blanket reintroduction of supervision. We're luckier, I think, than in Lothian because we have continued access to oral fluid testing, and my colleagues in the nursing team have done an absolutely amazing job and have come up with some really quite creative solutions as to how to try and carry on doing toxicologies for people where there have been concerns. So we've been going out and doing oral fluid testing on people's doorsteps. One of our nurses has done a testing clinic, drive-through or kind of walk-in testing clinic hidden behind screens in a GP car park. We've had nursing staff that have managed to sort of sneak into rooms here, there and everywhere across the borders to carry on seeing people that they've been most worried about. And I think that's been really, really positive in trying to help us feel that we're able to strike that balance between people who, there are concerns about the presentation, and concerns about their toxicology results, but without that kind of knee-jerk reaction to want to completely reintroduce supervision for everyone. So my hope is that we're managing to do that in a reasonable way, but I think it has definitely been a real challenge, particularly, as I say, with that very clear information from some of the drug deaths. So other bits, again, similar to Danny, that I feel have been very positive. You may have spotted that obviously those numbers have jumped up in terms of numbers of people in treatment from before COVID, and they will have gone up again. I think our service is actually certainly above 380, probably possibly up to around 390 people in service at this point. And that's been really encouraging actually to see that lots and lots of people have come forward and self-referred into service even during COVID. I suppose it'll be interesting in time to think about why that is, whether that has been around more limited access to street drugs, or whether there have been other reasons that people have chosen now to come into service. But what's been very positive again is that although we've had to massively adapt our way of working, we have managed to meet that demand. Certainly we've continued to meet all targets throughout the COVID period, and indeed that with only a couple of exceptions, that the majority of people have been seen and offered ORT within days of self-referring to the service, which I think has been a fantastic achievement by the team during a very, very challenging time. The other thing we've done in keeping with Danny and colleagues in West Lothian, so we also decided that we would go ahead and launch Buvidal even in the middle of the COVID period. And again, actually, it's been a really, really positive experience. We've had patients who have, I think, really benefited from it, both in terms of people who've been very, very anxious around COVID and not wanting to go to pharmacy. We've had several very chaotic patients who are simply repeatedly dropping off of scripts, and who do, in the last couple of months at least, have seemed to have stabilised a lot more on Buvidal. And we've also had very positive anecdotal reports from patients who said that if they have used on top of the Buvidal, that the buprenorphine has been at a point where it's really attenuated the effects of the heroin, and they've felt really quite comfortable on it. So we certainly will be aiming to make that much more widely available across the borders going forward, and we've got various different plans to try and do that. So I suppose just in summary, I think very much in keeping with Danny, we've had real issues around sort of these sweeping and massive changes, a lot of anxiety around that. We certainly have had very clear evidence that there is a lot of methadone being diverted, and I still am concerned about that. We've worked very, very hard to maintain our access to testing and face-to-face contacts with people, even if it is just a socially distanced walk or a contact on their doorstep where we're worried about people. And my hope is that through that we are trying to manage those risks as appropriately as we can in this period. We've had issues around the resource implications of needing to deliver so much methadone, and I probably don't have time really to talk about it, but you know, one of the real most challenging groups, although it's very, very small, has been people who are saying they're symptomatic or shielding, but there's also real concerns about their stability, and people who are then, we have anecdotal information that they're seen out and around the town looking very intoxicated, but of course they're telling us I'm supposed to be shielding at home, and managing those individuals has been really tricky, and taken quite a lot of time and careful thought. But overall, going forward, my hope certainly is that we'll see a lot of patients doing very well with reduced supervision, and I hope actually this probably will lead to a change in culture in the service going forward.
Thanks very much, Jamie. That's terrific. Again, a great overview of what's happened in your area. And we'll move on now to our third speaker, who's already appeared. So over to you, Saket. Thanks.
Hi, thank you, Dave, and thank you to the SDF for the invitation, and to the two previous speakers for keeping so well on time. I'm Saket Priyadarshi. I'm the Associate Medical Director for Alcohol and Drug Services across Greater Glasgow and Clyde Health Board, a health board which is at the opposite scale from which Jamie has described. We have over 9,000 people on opiate replacement therapy or medically assisted treatment, and more than 10, 12 teams, multidisciplinary teams providing services for them. I thought in order to not have a repetitive set of presentations for you, I just wanted to start off by saying that I agree very much with most of what James and Danny have presented to date, and our experience, although on a different scale, has been in principle very, very similar. I thought what I would do, though, is concentrate on maybe 2 or 3 areas of service that are particular, if not unique to us, make some observations from a general governance point of view around our experience in the COVID era, and then also to touch on at the end, I will maybe raise some questions about the challenges and opportunities of delivering services as we enter our recovery plans. So to begin with, some of the particular challenges we've experienced in Glasgow has been around the number of early prison releases. We have had in Glasgow, for example, to accommodate over 16 new patients into our treatment services over this period of release from prisons. And most of that has gone very well, but required a large degree of coordination between the prisons clinical team and our own community-based clinical teams. However, we have had several adverse events from those transfers from prisons to our teams, and most of them relate not to the continuation of treatment for opiate replacement therapy, which was agreed and possible in all cases, but actually due to the multiple and complex needs that the population, much of the population had, and often coming into Glasgow at a difficult time in terms of being able to address and meet those needs. Linked to that has been a very large challenge we've had with regards to the significant rise in the homeless population and the population in Glasgow city centre. Many of you will have seen media reports of how the city has responded by contracting with hotels in the city centre to accommodate much larger than expected numbers of patients, of people, many of whom who have problem drug use, and actually many of whom were not known to treatment services. And we've managed to engage a large number of them through our homeless addiction team and services, but that has been extremely challenging as well. A unique service to Glasgow is the Enhanced Drug Treatment Service, which provides heroin-assisted treatment. We had to unfortunately temporarily suspend that treatment near the start of April, but we've been able to reinstate that service, having engaged all service users in heroin-assisted treatment. We are now looking to expand the capacity in that service whilst observing all the COVID restrictions that we need to. Some observations around the clinical governance challenges in recent times. Again, not wanting to repeat what Danny and James have already stated. One of the challenges has been, of course, around supervision capacity in pharmacies, but also often in pharmacies, they have the discretion to stop supervision of their own accord. And we have had many situations where pharmacies have stopped all their ORT supervision, and there's been communication gap between the pharmacy, the team, and the prescriber. And often we've discovered this change some weeks later. And I think that's something we need to address as we move forward. And I'm focusing on perhaps areas of learning that we might want to further look into as we go on. The second more positive news is, as Danny and Jamie have highlighted, is that we've actually managed to engage a number of new patients, not people who are re-engaging with services, but actually people who weren't engaged or known to services previously. And perhaps the reduced supervision has been an attractive feature for them in terms of presenting to services. But I think there's a question about understanding what it is that drove people to treatment services and allowed them to engage at this time. Another challenge, another question for us is with regards to the monitoring of adverse events and in fact taking a public health surveillance view around outcomes for people in this current climate. There's been a significant challenge around the sharing of information, getting TIMUS information, and of course, we're all aware of the problems with regards to toxicology in Scotland. We've had to develop local agreements and local systems, and what we've done, and sometimes a crisis is a friend in this, is that we've been able to receive some information from the police, which has been very helpful, and develop our own dashboards for monitoring issues such as monitoring services like injecting equipment provision, but also non-fatal overdose presentations, certainly for our service users across the board. And that's helped to help the teams to respond to individuals as needed, but it's also helped our alcohol and drugs partnership to understand priorities for service change during this time. My own understanding of the data that we have is that there's been very significant rise in suspected drug-related deaths. Unfortunately, certainly in Greater Glasgow and Clyde. Unfortunately, we don't have detail enough to explain this, but anecdotally, as we heard previously, we are beginning to hear of prescribed methadone being diverted, being involved in some of these drug-related deaths. And I understand there's national work going on to investigate this further. As well as this, I just wanted to finish by saying there are some challenges and opportunities ahead. I think as well as medication-assisted treatment, one of the most effective interventions in drug services is therapeutic relationships, much of which is built on trust through face-to-face consultations with service users over a long period of time. Face-to-face contact, although we have prioritized and maintained a level of face-to-face contact, certainly for those most in need, we can't disguise the fact that we have not been able to engage in the same way with individuals as we were before. Now, actually, that might have helped others approach services and engage with services for the first time, but certainly that loss of therapeutic contact is something we all have to be mindful of. And the normal response has been around remote contact through telephone and through video consultations, hopefully. But there's a question, and I think the Scottish Drug Forum have a role around understanding this, or helping us understanding this. There's a question about what is the capacity of our service users and potential service users in engaging with us in digital manner. I think there's also something around, certainly in our area, a break between the prescription and appointments. And again, this comes with potential risks, but potential opportunities as well. And we would like to understand this further. We're entering recovery planning now, and increasing services, including testing, point of care testing and urine testing, as well as bloodborne virus testing for these patients who have not had this level of intervention done in the last 3 or 4 months is a priority. And then again, the question is, how do we do that when we don't have the same level of face-to-face contact? So there are many more questions that I could raise, but I'm sure they'll come up in discussions very shortly. So I'd like, again, thank you to SDF, and very happy to be involved in the conversation now.
Thanks very much, Saket. That's a really helpful overview as well. It's given us, between the 3 speakers, a really good picture of what has gone on. Can I invite the other speakers to return, please? And then we can have a discussion. I'll also ask my colleague Austin, who's going to join us, who's been sifting through the questions that have come in, and hopefully there's been a few of those. Can I just then turn to Austin, and do you want to give us a summary of the first question or set of questions that you've got?
Yeah, I think this has been answered by Saket in his last presentation, but I suppose it's something that's worth teasing out, is about seeing people for the first time, or maybe people we haven't seen for a very long time in treatment, presenting for treatment. So what's the scale of that? And does that vary across different areas of Scotland represented? And what do you think motivations are? I know it's speculation in that, but is there any sense of what's brought people there? Is that a change in their personal circumstances because of lockdown in drug supply and the ability to get drugs, or getting the money to buy drugs, or is it because of the change in the treatment regime?
Danny, do you want to go first on that one?
I was just furiously looking on the computer next to me to see if I could get referral numbers, but I failed to do it quick enough. I think we've certainly had lots of referrals, like I think Jamie and Saket have been saying. I'm not really sure of the reasons why we've got more people coming in. I certainly know anecdotally there are a lot of people who are asking now for injectable buprenorphine, and that has been word gets around. The patients who are on it are finding it a very acceptable treatment, and so certainly I've seen a lot of patients over the last few weeks who are specifically coming back to, or coming to us, or coming back to us. A portion of those people have been either never in treatment or out of treatment for 2 or more years because the burden of going to a pharmacy. I would be speculating on other stuff, whether it is about lack of availability of drugs. Patients comment to me that the heroin around at the moment is, if I can be slightly crude, a bit shite. But I hear that a lot, so I don't know whether that's unique to the current situation. But again, as Saket mentioned, I would just say that some of our new assessments have been happening up to a point over the phone. It's a really difficult way to try and engage somebody up front, we are, like other services, doing all we can to preserve our face-to-face contact, because it's just it's a very vulnerable period for people coming into treatment, and trying to establish that rapport is really difficult unless you can sit in a room with them.
Yeah, thanks, Danny. Jamie, do you want to add to that? Or?
Yeah, I'll try not to say too much because I don't want to just repeat everything Danny said. I mean, certainly, again, we've had the same anecdotal experience here of people talking about disruptions to the illicit drug supply. We've had exactly the same experience. So we've got patients at the moment who are reducing their methadone far faster than I would probably like them to because they're so keen to change onto Buvidal. And certainly some of that has been word of mouth. We've had some of our first few patients, we've had all of their friends in service now want to go into Buvidal as well. And I think that's a very positive thing. I suppose the only thing I would say is that I'm not so convinced that it's been because people are expecting a different service. Certainly in this area, we have prioritised people new into treatment, especially with methadone for daily supervision. And I can't actually think of anyone during the COVID period who's come new into service and has been titration onto methadone without daily supervision. And again, I've not had anyone turn around sort of angry at that, not expecting that, or sort of where that's not been acceptable to the patient, or it's caused them to drop out. So I'm not so convinced that that necessarily has been the case.
Okay, thanks. Saket?
Very little to add. I suppose, Jimmy, what I was again conjecturing on was the possibility that people are attracted to treatment knowing that for a period of time during the titration and stabilization period they would be supervised, but were more likely to come off supervision earlier in this present climate than perhaps in the pre-COVID world. But I think my query was, is this an area for more research?
Yeah, thanks. Okay, thanks. Oh, Saket, you disappeared there for a minute. Austin?
And the other question, I suppose, is a bit of reflection for yourselves in terms of, are you able to say to yourself that the people who are doing well in terms of the take home, and you feel more confident about them over these weeks, the people you would have forecast would do well, and obviously conversely, the people you were concerned about are the people you were rightly concerned about?
Saket, do you want to go first on that one? We want a summary on the 9,000 people and the breakdown of that.
Well, I can do even better than that. I can tell you that I haven't actually written a methadone script during this time because my colleagues do that for me. But I have had feedback from them. They've been pleasantly surprised by the number of people who've done okay and done well on the reduced supervision. And like the other areas, we don't intend to go back to our previous prescribing practice, which was quite heavy on supervision. But in terms of any more detail than that, I'm sorry, as I work in the whole heroin-assisted treatment service, so I'm not able to give you much more detail than that just now. Maybe the others are.
Yeah, Jamie?
So again, my sort of reflection would be that, so I suppose unfortunately, yes, there have been some people who we worried wouldn't do well and who clearly haven't done well. At the same time, the opposite has also been true. There have been people that I've been really delighted because they've done much better than I thought they would. I suppose the thing that I'm still slightly worried about, maybe it's just my own anxious nature, is just the number of people that obviously we are still prescribing for, that we've had no face-to-face contact and no toxicology for over 3 months. And I suppose it's the sort of the unknown. It's how many of those people are doing well, as opposed to us just assuming that they are doing well at the moment. So certainly the key thing in our recovery plan as of this week is we're now creating a list of all the people that have not been seen during COVID and are now trying to arrange face-to-face contacts for them, ideally within the next 4 weeks. And hopefully that will give us more of an answer.
Yeah, okay, thanks. Danny?
Yeah, I think much the same. It's been a bit of a mixture. I've been delighted that some patients who I have always worried about have done very well. But there's people who haven't done so great. I think we don't want to go straight back to how we were before. I think any clinician, anyone working is aware that the treatments we offer, for better or for worse, can be quite stigmatizing, and anything that we can do to accommodate people's people having benefited from removing some of that, I think, you know, we'll capitalize on. But yes, it's been a mix.
Yeah, and I guess one of the other aspects to that is just, you know, the fact that people not going to the pharmacy so often. So for some folk, that is actually a harm reduction measure, in the sense that they're not confronted by people selling benzos or people trying to take their methadone from them.
Absolutely, and that's anecdotally, people have said that, and I think you know, we know that the pharmacy queue is sometimes not a great place to be.
Yep. Okay, thanks. Austin.
Yeah, there's a few questions or points around diversion. So one of them was about what's the drivers for that diversion? Is it a COVID specific issue around people not having money and having no other ways of gaining money that might have been open to them before lockdown, in terms of shops being open and towns and cities being busier, and that sort of street scene that goes along with that? And also, is one of the drivers simply that there are a number of people who could benefit from treatment who aren't in treatment and still don't present for treatment, and therefore they'll always present a market for diversion?
Jamie, do you want to take that first?
Yes, I suppose again, I wish I had some data, because I feel that it's anecdote and speculation at this stage. Certainly anecdotally, I think there have been a few of our patients where I think it's probably been that you know, they've taken the opportunity to fund street heroin use by diverting their script. There have been a few situations that I've been very concerned about where it's been quite vulnerable women who've had men diverting their scripts to them. And we've been keen, obviously, to act on that very quickly. So I think it probably is a variety of different reasons, but I think it would be an area that, you know, I'd be really keen to see some research and some data over time that comes out of this to explore what reasons and motivations there may have been.
Yeah, Danny.
Yeah, I mean, I don't really know about the motivations for the diversion. Yes, I am anecdotally aware. I could keep using that word, but I think, you know, it's one of the ways we kind of keep in touch with a larger population who we're not necessarily treating. I'm anecdotally aware that there are people in our patch who maybe we've had contact with in the past, or maybe we haven't, who are opting to do their own treatment with diverted methadone, and you know, I think that's just a reality. I would prefer that they were in service with us, because I'd like to think that we offer more than just the methadone, but I suspect that's part of it.
Yeah. Saket.
So very little to add to the above. I agree with all, and I think Austin half answered the question that he asked himself in his speculations. I suppose, to use a cliche, Dave, COVID has shed a light on a lot of underlying problems, and in this area, there's something around real-time drug surveillance data, real-time information around street drug use, real-time information about what's driving people in or out of treatment. And I think, despite being in week 14 of this, or is it even further? I don't know, I've lost track. But despite being more than 3 months into this, the situation, we're still struggling for really key intelligence that would help us adapt our services appropriately.
Yeah, no, that's a good point. Austin.
And this is more of a solid question, which maybe you do have some data for. It's about naloxone provision, obviously, in light of the issue around overdose, and certainly obviously fatal overdoses. Have we found creative ways of getting naloxone out, or have we got a sense that there's more being supplied than previously?
Saket, do you want to go first?
Yeah, so naloxone has been really an important part of our strategy, certainly in Glasgow and certainly in Glasgow city centre. Our naloxone supplies have actually increased, and linked to that is a very significant though anecdotal increase in use of street naloxone or naloxone in the street drug using population, certainly. Some of the things we've done around that include we have a mobile van. We've ran a different service from that mobile harm reduction van, which has been a very assertive, very active naloxone supply service, for example. That's the least it's been able to do, as well as actually injecting equipment provision. So we've managed to increase our injecting equipment provision supply to that population, that targeted city centre population, very effectively. And I have no doubt that that's positively linked to controlling the situation to some extent within the city centre. So yeah, yes, naloxone is a priority. Different models of delivery are being developed, but there are of course challenges when you don't have the same level of direct face-to-face contact. And of course, you know that changes in supply guidance or legislation has come through as well to allow different routes of supply as well, which I think was helpful and timely.
What about postal supply?
So yeah, we're linked in with the postal supply project, the system. I don't have data to tell you what the uptake of that has been, but my understanding, speaking to our naloxone lead, has been that it's helpful, but not at the volume that really compensates for the other problems that are going on.
Yeah, Danny.
So I'm going to have to take a pass on actual figures for naloxone. We are certainly still handing it out. We're very lucky in West Lothian. We have a spectacular third sector partner who does an assertive outreach IEP and naloxone service where people can simply send him a text message and he will go out and home deliver. And so that's still happening. I was just quickly checking one of our local dashboards. And so whilst it's not naloxone specific, we have had an increase in injecting equipment provision, both in terms of number of transactions and clients. And I suspect that's probably been down to the home delivery.
Yeah, okay, thanks. Jamie?
Yeah, not massive amounts to add. So, I mean, we've tried to come up with every creative way we can to get people naloxone. So we have had nurses taking it out and leaving it at community pharmacies to be given to people when they're picking up. We've been posting it through letterboxes. We've been giving it out in car parks. We've been doing anything we can think of basically to maintain people's access to it. I don't have any figures in front of me. I think anecdotally, certainly, it probably will not be quite as high a supply as it was when we had more direct contacts. And I'd be keen that we continue to really just explore every avenue to get it out there into our client group.
Okay, thanks. Austin?
There's a few questions on urine testing or testing in induction into treatment. So has that regime changed, or is the possibility for that to change, and how's that managed now? And also questions about the alternatives to urine testing. Could be doing some other form of testing or not doing testing at all.
Danny, do you want to go first? You mentioned oral testing, I think, in your area as well.
So I think just for a little bit of context, I think NHS Lothian, although I suspect also Jamie in the Borders, because I think he might be using our labs, but I'm not 100% sure. So we're in a slightly unique position. So we do oral fluid testing is our normal way of testing, and it's done locally in our biochemistry department at the Royal Infirmary. It's a pretty spectacular service. We get a breakdown of types of benzodiazepines, including street benzos like tizolam. So that's been our standard of care. That's the testing that we have lost. We do still have access to urine testing by the lab, and we also use some point of care urine testing. So when I say we've lost our toxicology, I guess we've lost our routine toxicology. I guess speaking for myself as a clinician, I'm less interested in a rigid rule and more thinking about what it is that I'm trying to do. So if I've got somebody who I'm trying to, or I'm considering treating with OST, what do I want to know? Well, I want to know that they're opiate dependent, and that's not entirely down to toxicology. It's a clinical assessment, and you know, I'm not going to necessarily rigidly adhere to you must give us 2 samples and they must be separated by whatever period of time in order to start treatment. But it's a case by case. So where it's been clinically necessary, and for the majority of people, I would ask them to give a point of care urine test. But of course, there's going to be circumstances where we do something different.
Thanks, Jamie.
Yeah, so we're in a slightly different position to Danny. So the Lothian service for toxicology is absolutely amazing, and we use that for our urine testing. I'm very keen that we actually shift and gain access to their oral tox service, but we hadn't managed that prior to COVID. And as a result, actually, it's worked out, I suppose, better because our current private provider has carried on doing oral fluid testing throughout COVID, which means we didn't lose access to it. Before COVID started, we had really been focusing here on sort of low threshold prescribing. So I'd written whole new protocols about how we assess people very rapidly and bring them into treatment. I don't have the exact figures, but I think prior to COVID, it was about 60% of people were started on ORT on the same day presenting into service. So as part of that, we have accepted, like Danny says, that our assessment does not rely on the traditional 2 tests at fixed points in time. So our protocol really talks about the idea of a point of care test when they're seen, and then gathering enough other information to be satisfied that there's clear evidence of dependence or really significant harmful use of opiates. We would normally be looking for that. So, for example, obvious injection sites, or with some patients, even if it's day 1 in the NHS service, when they're well known to our third sector partner and they're able to give clear collateral of a few weeks of engagement with obvious other evidence of very harmful drug use, we would accept that. And my view is that delaying access to treatment to seek that traditional testing model isn't appropriate, and it's not what we do.
Okay, that's great. Thanks, Saket.
Yeah, no, I absolutely concur with Jamie there. So we've managed to really have quite a high percentage of new patient starts in most of our treatment teams. Same day starts, sorry, as in most of our teams. We're taking the same approach that's just been described. I think also that's particularly relevant for new patients. For new patients, our approach very much is we'll do the first consultation on the phone and then bring people in a controlled environment, in a controlled triaged way, and we'll get a point of care test done as well as the physical examination done at that time as well. And that seems to have worked fine. For people who are well known to services and who are re-engaging with us, and of course we're thinking about what the length of time between the last prescription and this prescription is. For people who are well known to us, we may be able to even curtail even that significantly as well. So yes, a huge attempt being made to be responsive, to be pragmatic. Our routine testing is point of care urine testing. We don't really use labs unless we're looking for confirmation. And I suppose the challenge for us going forward is not really around new patient starts, but around general monitoring when you don't have the same clinic set up, when you don't have the same face-to-face on-site contact with service users. And that applies to bloodborne virus testing as well, which is a huge priority, certainly in this health board, and much of which is done opportunistically as part of that sort of contact with service users. And we're really seeing very, very steep falls in numbers in terms of our bloodborne virus testing, and we've got a challenge ahead of us. We've employed some specific staff with new ADP monies who are going to have a protected role around outreach and bloodborne virus testing to help us make up for some of that deficit. but it's a real challenge to do the testing in the near future.
Okay, thanks. I don't know if any more questions coming through, Austin. I was thinking maybe we'd ask a more general one about what, next steps, unless there's anything that is urgent.
Well,
there.
As the first half of that, perhaps I could read out a question, obviously anonymously, but the question is, how do the panel think we can move forward with the same creativity and dynamism as services have displayed during this difficult time, without reverting back to the needless meetings and bureaucracy that have strangled us before?
Okay, well, this is the last.
Is that the question you have in mind?
Well, more or less, yeah. Okay, Saket, do you want to go first on this one? No.
Meetings and bureaucracy. Why would you want to get rid of that? I think it's very clear that actually the contingency plan was much easier to implement than the recovery planning. Recovery plans are, because with COVID restrictions, with the staff levels that we currently have and the impact of COVID restrictions on staff, with the buildings that we have and the impact of COVID restrictions on how we can staff the buildings, and all the limitations around digital capacity, not just for our services, but actually for our service users as well, potentially. Well, not potentially, I mean, in reality. I think somebody described, I think the question was, how can we maintain the creativity? Actually, we weren't that creative, we were just pragmatic, yeah? You need to be much more creative to figure out how to deliver services moving forward. And I think that, I don't have an answer to that, but I think I am very concerned about the digital capacity that we have to engage, but I'm also concerned that we will lose meaningful therapeutic contact in that as well. So okay. I don't have answers. I'm raising questions. We're working hard on it. We're working hard on it, and medication-assisted treatment will be an essential component of our recovery plans, and maintaining what we've done so far and building on it will be an essential component of that.
Great, thanks. Jamie.
Yeah, I mean, I'd agree with everything that Saket has just said. I think for me that it's going to be a case of seeing what are the changes to practice that are actually have demonstrated that we can do things particularly more quickly and more safely than perhaps we thought we could. So for me, I don't know really how to describe my practice at the moment. I mean, I don't know if ultra low threshold prescribing would be the right way, but certainly even what I thought was low threshold rapid access to service before, it has forced me, and exactly it has been very much because I've had to take a pragmatic approach to think about how do I lower those barriers even further, particularly in a very wide geographic area. Where certainly for us being able to actually get access to people and see people, and I feel that actually some of those practices, whereas if you'd been speaking to me 4 months ago, I might have said, oh, that's very risky. I'm now kind of going, well, actually, is it? And we've been doing it, and actually it seems to have benefited people rather than causing harm. So there are definitely some things that I want us to hold on to, but I think very much like us, Saket, I mean, so I have offered so many patients the chance to use Attend Anywhere to speak to me. I've so far achieved it with none, and we've had to access both NHS and third sector money to buy mobiles and post them through people's letterboxes, because in a big wide geographic region, even staying in touch with some of our more chaotic service users has been really challenging, and I am really worried that the thing that we're really losing is that therapeutic relationship that is so vital between the key workers on our teams and the patient group, and for me getting that back as quickly as possible. So the things that we're trying here is we're doing lots of things like socially distanced walks, so key workers are meeting patients to have a walk around the park with them, so forget anything about testing. prescribing, but just having that contact. We've had service users that when we've offered them, would you like us to come to your doorstep to do a socially distanced oral fluid test? They've been delighted, and I think that's the contact rather than anything to do with the test. And we're pushing very, very hard here to get access to clinic rooms. Actually, we want to start being able to invite people to come back and meet, even if we're having to use PPE and swabbing rooms down. We think that's worth it, but it is proving very challenging.
Oh, that's great. Thanks, Jamie. Danny, we're just about out of time, but we'll give you the last word.
I mean, I'll be brief. Again, I think it has been pragmatism rather than necessarily great leaps of creativity, but we have pragmatically reorganized how we allocate medical and nursing time to accommodate same-day clinics, 5 days a week, and that's something that we will we will continue. I think there's certainly an appetite to try and keep this stuff going. We all work for at times risk averse and occasionally bureaucratic organizations, and I think it may not always look like it, but my impression is that all the clinicians, all the service leaders, we do want things to work properly, and we do want good outcomes, and we are sometimes fighting behind the scenes to make things be a bit more nimble, but we'll just keep doing that.
That's great. Thanks, Danny. That's a great point to end on, I think, in terms of all the learning that we need to do, and matching that against what's happened so far. So that's great. Unfortunately, we've come to the end of the webinar, but this has been recorded and so will be published on the SDF YouTube channel as soon as possible. You can also view all of our previous webinars there. We'll be sending out an evaluation, and it would be excellent if you could complete that for us. Our next webinar will be held next Friday on the 10th of July at 1 o'clock. The focus of the webinar will be on the experience of people who use image and performance enhancing drugs during and after lockdown. A link to register for this webinar will be included in the evaluation email you'll receive, so it would be great to have you join us again. So finally, I'd just like to thank all of you for attending today, and a special thanks to today's speakers, Danny, Jamie and Saket, for what has been a very informative session. I'm sure you'll agree. Thanks again and goodbye.